Good morning, and thank you for asking me to speak. That's a hard act to follow, Cece, so bear with me. So I've been asked to talk about how to achieve preemptive living donor paediatric renal transplantation. So as we all know, preemptive living donor renal transplantation improves the morbidity and mortality of children with end-stage kidney disease and is widely accepted as the gold standard for renal replacement therapy. So I just wanted to address our programme at Great Ormond Street and what we've been doing. We did our first living donor transplant in 1990, and since then we've done 583 paediatric transplants, 290 have been living donor, and 293 deceased donor. Annually, as a team, we probably have about 100 recipients that we're working up for transplant, and test approximately 80 donors annually. We look after the children within the NHS, children with complex needs from out of centre, children under the NHS2, such as children from Malta, and the International Private Patient Programme. Children should be about 10 kilos at the time of transplant, and probably the earliest that we can get them to transplant is 15 months, which is probably a little bit ambitious by the time they've had all their scans, their vaccinations, etc. This is just a chart of the transplant numbers from 2006 to date at Great Ormond Street. The green bar is the living donor transplants, and the orange bar is the deceased donor. And as you can see, our living donor numbers are higher than our deceased donor. I also wanted to look at the preemptive numbers that we've achieved since 2014, 2015. So, excuse me, the green bar is the children who received transplants who were not preemptive, on dialysis beforehand. The orange bar is the number of children who've received preemptive transplants, and then breaking that down, the red bar is the living donor preemptive, and the purple bar, as you'd expect, smaller, is the deceased donor preemptive. And as you can see, we do more non-preemptive transplants than we do preemptive. And this is just a slide which I stole from NHSBT, just looking at the transplant numbers across the UK in the paediatric setting. So how do we achieve preemptive living donor transplant? And I just thought I'd say a few key points. So I think early referral to the low clearance team is the number one, ideally with a GFR of about 20 mils per minute. And the Renal Association guidelines state that referral should take place at least 1 year before the need for renal replacement therapy is anticipated. I know sometimes that can be quite difficult to gauge. There's a large team involved in achieving this. All members should be involved, so the recipient coordinators, the living donor team, the nephrologists, the surgeons, the clinical transplantation laboratory, psychosocial team, dietitian, play specialist, other disciplines are involved with the care of the child, and the professionals from other centres. It's imperative there's good communication within your team, and of course also across the different sites, and that should be coupled with very good documentation. The barriers to achieving preemptive living donor transplant, a late referral, particularly in complex cases, children from out of centre or overseas, limited donor suitability or limited number of donors, children's diagnosis, so children who require a nephrectomy prior or nephrectomies prior to transplant, such as FSGS, congenital nephrotic syndrome, or Wilms tumour, children who present with end-stage kidney disease at birth requiring dialysis, children with complex urology who need lots of operations prior to transplant, and we term them as our crash landers, so children who present on the unit in end-stage kidney disease requiring dialysis. So I'm just looking at our preemptive transplant numbers from last year, and we audit our practice annually, and this is from last year's audit. So 12 out of our 23 transplants at Great Ormond Street were preemptive. So then what we do every year is we break down the ones who weren't preemptive to see if we could have improved this. So we had 6 crash landers, 6 children who presented in end-stage kidney disease onto the ward. 2 children required nephrectomies prior to transplant. 1, there were problems with the donor, so they needed to go onto dialysis. And 2 children, their end-stage disease deteriorated very rapidly, so they needed hemo before they needed to have a transplant. So the team is quite large. Looking at the team, there are 2 recipient coordinators, 2 nurse specialists, and we have admin support. We work very closely with our donor coordinator at Guy's. We have 5 nephrologists, 3 who work in the pre-transplant setting and 2 post-transplant. 5 transplant surgeons who are based at Guy's, who also cover Evelina and Great Ormond Street. We have a psychosocial team, including a play specialist and a renal dietitian. And all of these people are very much involved in achieving this goal. Just thought I'd quickly skip through how we work someone up for transplant. First of all, we're presented with the child. We'll do a blood group. We'll do their HLA typing, send that to CTL at Guy's, and we'll do check their HLA antibodies. We'll perform an initial cross-match with their donor if they have presence of HLA antibodies, they've had a previous transplant, or if we're advised to do so by the lab. And we'll do ABOI titers if our donor is in blood group incompatible. We're then presented with the donor fairly early on, hopefully. They'll meet us. We'll get a basic medical history just to rule out any diabetes, etc. We'll register them on our system. We do the blood group and HLA typing on the donor with us, and we explain the HLA typing and the implications of that test. Give them a transplant information pack, and then we refer them over to Guy's. We're also presented with donors from overseas. We'll obtain a blood group if we can. We'll try and get HLA typing done locally, but that can often prove difficult. So the typing's sent straight over to Guy's. And if all those results are okay, we then refer them over to the donor team. Going back to the recipient, all the children should be fully immunised prior to transplantation. They should all have their routine vaccinations. As well as that, they'll require varicella vaccination if they're varicella negative, a measles booster if they're measles negative despite their routines, hepatitis B vaccine, and we check their CMV and EBV virology every 3 months. We look at their coagulation, often disordered, so we'll refer them to the haematology team. Look at their liver function, again, often disordered, so we have to refer them to the liver team. And if they're a high risk of diabetes post-transplant, we'll do a fasting glucose and a HbA1c. Looking at their imaging, we ultrasound their abdominal vessels, looking at their IVC and iliacs to ensure they're patent. Children may need to go on and have further imaging, such as an MRV. We do this in all children under 20 kilos, if they've had femoral lines previously, or a previous transplant, or if they have complex anatomy. We'll do a neck ultrasound if they have had previous neck lines. They'll have a yearly echo and referral to cardiology if needed. And we'll look at their bladder. Many of them have bladder issues as well. So we'll do a basic bladder ultrasound just to make sure the bladder empties, but many of the children are already under urology. And then look at the need for nephrectomies prior to transplant. As I said, most children, or 50% of our children, I would say, have urological issues. So they're referred to the urodynamics team. They may just go forward for have bladder function assessment or formal urodynamics. I'll talk about our MDM meetings later, but when we have them, we insist the urologists are there with a good urology plan, and the bladder plan should be documented prior to proceeding to transplant. Just talk about dental hygiene, make sure that all the children are under a dentist. The anaesthetist will review them, usually at the MDM, but will individually review them if they're complex. We sign off from all the other specialities, particularly liver, cardiac and metabolic, the ones who we seem to work with most closely. We need to book a PICU or a CICU bed if it's needed. We need to think about intraoperative support with the complex cases, such as CVVH. Think about, do we need an extended theatre list if it's a complex case? All children must have an MDT meeting and sign off prior to proceeding to transplant. And once all that's done, the consultant nephrologist will sign off the protocol. Also, very importantly, all families should have psychological preparation prior to transplant. So the team will talk about the practical aspects of transplants, particularly with living donor, when one of the donors is a parent, so you're excluding one of the carers. Think about care of siblings, loss of earnings, the impact on the whole family, and very importantly to talk about the follow-up care and what we expect of them and their engagement within that. And we very much involve the play specialist with help for preparation. So all children have an MDT or an MDM prior to proceeding to transplant. We do that once a month. And looking back on our last audit year, more than 50% of the children required more than one MDM because of the complexity of their disease, and actually one child had 6 MDMs before proceeding to transplant. At the MDM, we have the whole team, the surgeons, the urologists, and any other specialities who we feel should be there to get sign-off. And just to back that up, we were looking at the last audit year, the specialities involved with looking after each child. And as you can see, over 50% of the children the last year had more than one speciality at Great Ormond Street. And again, one child had 6, probably the same one who went to MDM 6 times. So once we've had sign-off, we're approaching transplant. The children and the families will meet with the consultant nephrologist in the pre-transplant clinic. They'll meet with the transplant surgeon, usually more than once. They will meet with them. The CNSs, we will back up with discussion, make sure they understand what's ahead of them, talk about the follow-up, the drugs, do's and don'ts, when they can return to school, etc. And then we'll confirm the date with the lead surgeon, with Guy's Hospital, the ward, and the family. If the child's under 20 kilos, they'll have a PICU bed booked, the hotel's booked for the family, and the final flow cross-match is carried out the week before. And then the very week prior to transplant, they'll meet again with the surgeon where they'll, as I said, have the final flow cross-match. They'll start their immunosuppression, they'll sign their consent, have a routine baseline chest x-ray, finalise their admission plans, and have consultant sign-off. For children who are going on call, it's very much a similar procedure as it is with a living donor. Just very quickly to mention the donors, who are obviously very important in all of this. We work very closely, as I said, with our team at Guy's. We refer them over, and then they are sent a letter from the Guy's team. Once they receive that letter, they have to make the contact themselves, as we do not want any coercion or us to be pushing them to make contact. From that point onwards, all the donor workup is done at Guy's with Anita. We keep it a very, very separate entity, which the families struggle with a lot. And Anita and I will hand over every week, see how we're going. And then they'll have their full donor assessment at Guy's. And at the end of that, once they've passed, they'll go to independent assessment. So in summary, as you can see from the slides, it's difficult to achieve preemptive donor transplantation because of the reasons I've said. But I think early referral, good communication are key, and we should go back and discuss transplant options regularly. So if you have a child who's on the deceased donor list, go back and readdress living donation. Have they discussed it with families? Have they reached out further? And just thanks to Jenny, my colleague, Anita, and the teams at Great Ormond Street and Guy's. Thank you.